Today we are going to do reproductive pharmacology, and first we are going to discuss the control of reproductive hormones. So obviously this is the hypothalamus and it produces gonadotropin-releasing hormone. This gonadotropin-releasing hormone goes and acts on the anterior pituitary to produce luteinizing hormone and follicle-stimulating hormone. These steps are acted upon by various drugs. The combined hormonal contraceptives act here on the hypothalamus and on the anterior pituitary and inhibit both the hypothalamus and the anterior pituitary. Then there's this very important drug known as clomiphene. It acts positively on the secretion of gonadotropin-releasing hormone, and it is used to treat anovulatory infertility. This is a very important drug. Our next drug is degarelix. It is a gonadotropin-releasing hormone antagonist, and it acts on the gonadotropin-releasing hormone to inhibit its production. Then we have gosrelin and leuprolide. They positively or negatively affect the gonadotropin-releasing hormone secretion. And next we have again combined hormonal contraceptives that act on anterior pituitary and hypothalamus, and danazole that acts on anterior pituitary and inhibits it. The anterior pituitary then secretes luteinizing hormone and follicle stimulating hormone that act on the gonad producing organs, ovary and testes. Sorry, gamete producing gonads. So the ovary produces two hormones, androstenedione and testosterone. Um, Now, the androstenedione gets directly converted into estrone by aromatase, and testosterone gets converted into estradiol in the presence of aromatase, and estradiol can get converted into estrone, or it can get converted, or it can directly act on the estrogen receptor. So, when the ovary produces androstenedione, it does so under the influence of CYP450C17, and this can be inhibited by ketoconazole and danazole. Danazole was acting on the anterior pituitary and also on the CYP450C17 enzyme that causes the stops the production of androstenedione. In the next step, aromatase inhibitors are anastrozole, letrozole, and exemestane. We are going to study what these drugs are, but they're aromatase inhibitors for now. And estradiol acts on estrogen receptor, which can be positively or negatively influenced by tamoxifen and raloxifene. Estrogen receptor then causes gene expression in estrogen responsive cells. Next, we have the testes. The testes produces testosterone under the influence of luteinizing hormone, and abiraterone, ketoconazole, and spironolactone inhibit this step. Ketoconazole also inhibits this step of ovarian production of androstenedione and testosterone production of testes. Then we have testosterone get converted into dihydrotestosterone in the presence of 5-alpha reductase, or it gets directly attached to androgen receptor complex. The dihydrotestosterone is produced under the influence of 5-alpha reductase, and this is inhibited by finasteride, which is a very important drug again. And the androgen receptor complex is inhibited by flutamide, by bicalutamide, and spironolactone. Spironolactone again acts on two positions, um, on the production of testosterone and also negative influence on the androgen receptor complex. And this androgen receptor complex under normal conditions would cause gene expression in androgen responsive cells. So again, combined hormonal contraceptives act at two positions, the hypothalamus and the anterior pituitary. Danazole acts on two positions, the anterior pituitary and CYP enzyme. Ketoconazole acts on the CYP enzyme and the testosterone formation, and spironolactone also acts on the androgen receptor complex as well as the testosterone production. If we now go to the drugs individually, the first is gonadotropin releasing hormone analogs. These are leuprolide, gosrelin, nephrelin, and histrelin. So, leuprolide and gosrelin, these are analogs. And we also had nephrelin and histrelin, which are not mentioned here, but they're also analogs. So we are discussing gosrelin and leuprolide, which are the analogs of gonadotropin-releasing hormone. They act as gonadotropin-releasing hormone agonists when used in pulsatile fashion. When used in continuous fashion, they first transiently act as gonadotropin-releasing hormone agonists and cause tumor flare. but subsequently act as gonadotropin-releasing hormone antagonists and downregulate the gonadotropin-releasing hormone receptors in the pituitary and decrease FSH and LH. So that causes a decrease in females and decrease in testosterone in males. Can be used in lieu of gonadotropin-releasing hormone, this leuprolide. So I'd like to see what a tumor flare is. Mhm. Temporary and sudden worsening of symptoms or tumor markers in cancer patients. So what they're giving this for is to decrease gonadotropin releasing hormone, these analogs. But when they are given in pulsatile fashion, they used as an agonist. Pulsatile fashion would be to give the agonist according to the release of gonadotropin releasing hormone um, in a wave-like or pattern-like manner, because the anterior pituitary does not secrete, sorry, the hypothalamus does not secrete gonadotropin-releasing hormone in a continuous manner. It does so in a pulsatile fashion. So if you give it these analogs in a pulsatile fashion, they're going to act as agonists. And when they're going to be used in a continuous fashion, at first they're going to act as agonist and they're going to make the condition they're being used for more adverse and the symptoms more aggressive. But after some times, because of an increase in gonadotropin releasing hormone in the body and their agonist, they're going to downregulate the gonadotropin releasing hormone receptor. And the receptors in the pituitary are going to downregulate. So the pituitary is going to produce less FSH and less LH. And so the hormonal response is kind of inhibited and decreased. And so the estrogen and testosterone is going to decrease. So these analogs will act as antagonists when they are used in a continuous fashion. Their clinical use is uterine fibroids, which was also known as leiomyoma, endometriosis in the uterus, precocious puberty, then in the males, prostate cancer, and infertility. Pulsatile for pregnancy, continuous for cancer. So we are giving it for cancer, and that is why there was a tumor flare when they were given continuously in at first. But it gets better with time, so that is why it is given for cancer. And the pulsatile is given for pregnancy, where it acts as agonist. So the pulsatile is the agonist function for this is used to treat um, infertility, and the antagonist function is for cancer. Except that there is uterine fibroids, endometriosis, a uterine condition, a leiomyoma, another uterine condition, endometriosis, precocious puberty, and a condition in male that is prostate cancer, and again infertility. Pulsatile for pregnancy and continuous for cancer. The adverse effects are hypogonadism. The size of gonads is going to decrease because there is an increase of the no, because they act as GnRH antagonists, so there's decreased estrogen and progesterone and decreased FSH and LH, and they're going to be decreased, and there's going to be decreased libido, um erectile dysfunction, and obviously nausea and vomiting. The next one is a gonadotropin-releasing hormone antagonist. These were also antagonists when used in continuous fashion, but this one is pure antagonist, Degrelax. And it does not have any startup flare because it is a pure antagonist and it won't first act like it's an agonist and flare it, so there is no startup flare. And thus it is used for prostate cancer. Its adverse effects are hot flashes and liver toxicity. Then we have ethinyl estradiol. It binds the estrogen receptors, and its clinical use is that it is used for hypogonadism because it is an estrogen analog or ovarian failure. It is also used in contraception combined with progestins. HRT in postmenopausal women, used for less than 5 years to lower risk of adverse effects. So it is used for contraception and hormone replacement therapy in postmenopausal females because they have decrease in estrogen, and it is used for less than 5 years because an unopposed estrogen can cause endometriosis and other conditions related to the uterus involving endometrial hyperplasia. So it is used for hypogonadism or ovarian failure and contraception with progestins and HRT in postmenopausal females. The adverse effects are increased risk of endometrial cancer when given without progesterone. And there's also going to be bleeding in postmenopausal patients. There's going to be hepatic adenoma, breast tenderness because estrogen acts on the breast tissue, and there's going to be an increased risk of thrombi which is a very important risk factor for estrogen because estrogen causes increased thromboembolic events. The contraindications are in people who are greater than 35 years of age who smoke tobacco. There's increased risk of cardiovascular events, and that's why when you have to advise this drug to any postmenopausal females or females above the age of 35, you ask them if they are cigarette smokers or tobacco smokers, and if they are, then you do not give ethionine estradiol or estrogen analogs, because there's going to be an increased risk of cardiovascular events. Patients with increased risk of cardiovascular disease, including history of venous thromboembolism, coronary artery disease, stroke, and migraine, especially with aura, and breast cancer and liver disease. Because it is estrogen acts on the breast and it is going to make it worse, and also liver disease. So the adverse effect, if we relate it to the adverse effect, risk of thrombi correlates to the contraindication of giving it in people who smoke. Breast tenderness gives it in the people with breast cancer, and hepatic adenoma gives it in contraindicating it in people with liver disease. And bleeding can be associated with no, bleeding cannot be associated with migraine unless it is stroke that is an adverse effect, which is not. So bleeding in postmenopausal women is an adverse effect, and migraine is a contraindication. Then we have SERMs, or selective estrogen receptor modulators. These are very important because they can act as agonist or antagonist depending on what they want to. The first one is clomiphene, again very important. This one was acting right here on the gonadotropin releasing hormone, and it was giving a positive effect here. Let's see how it does elsewhere. So it is an antagonist at estrogen receptors in the hypothalamus. Okay. It said a positive here, a positive response to gonadotropin releasing hormone, but a negative one to estrogen receptors in the hypothalamus. Okay, so basically the hypothalamus has estrogen receptors and it detects the estrogen. If there's a lot of estrogen, the gonadotropin releasing hormone is going to have a negative feedback, but if there's um, um, less estrogen, then it is going to be released. So it is basically going to cause the estrogen receptors to be antagonized, and when they're going to be antagonized, there's going to be more gonadotropin releasing hormone. This it acts on increase in production of gonadotropin releasing hormone, clomiphene. It prevents normal feedback inhibition and increases the release of luteinizing hormone and FSH from pituitary, which stimulates ovulation. As I said before, it is used for treating anovulatory infertility. Used to treat infertility due to anovulation, example PCOS. It may cause hot flashes, ovarian enlargement, multiple simultaneous pregnancies, and visual disturbances. Hot flashes, because there's going to be increase in LH and FSH, there's going to be ovarian enlargement, and because there is a lot of LH and FSH, there's going to be an increase in estrogen in the body, but the estrogen receptors in the hypothalamus have been antagonized, so it cannot detect it. So because of this increase in estrogen, there are going to be hot flashes, ovarian enlargement, multiple simultaneous pregnancies, because there's going to be a lot of ovulations and you never know which ova are going to be fertilized by sperm and which are not. And so there can be multiple simultaneous pregnancies and visual disturbances. The next is tamoxifen, which is also very important. It is an antagonist at breast, partial agonist at uterus and bone. So we have studied this one in, I think, hematology and oncology module as well, that tamoxifen is a selective agonist, and it is an agonist at uterus and bone, and it is an antagonist at breast. So it causes hot flashes again and increased risk of thromboembolic events, especially with tobacco smoking and endometrial hyperplasia or cancer, and it is used to treat and prevent the recurrence of estrogen and progesterone positive breast cancer, and to prevent gynecomastia in patients undergoing prostate cancer therapy. So what happens here is that tamoxifen has antagonist effect at for the breast cancer, right? So the estrogen and progesterone positive breast cancer, it is going to antagonize, because it is going to antagonize the estrogen and progesterone receptors in the breast. But in the uterus, it is going to cause a pro estrogenic effect, and it is going to cause endometrial hyperplasia there. So it has the effects of, if we correlate it with ethynyl estradiol, it is going to cause the effects of endometrial hyperplasia, and it is going to cause hot flashes and increased risk of thromboembolic events, just similar to that of the increased estradiol effects on the body, but they're not going to be effects on the breast, such as this breast tenderness or breast cancer, because it is basically being used to treat this breast cancer. And the second use has to be in to prevent gynecomastia in patients undergoing prostate cancer therapy. So it is basically an antagonist of estrogen at breast and an agonist everywhere else. That's the mixed function. Clomiphene again was an antagonist at estrogen receptor in the hypothalamus, and tamoxifen is an antagonist at breast. Then comes raloxifene. It is an antagonist at breast and uterus. Okay, so both of them. And it is an agonist at bone only. It causes hot flashes, again, like tamoxifen. It causes increased risk of thromboembolic events, especially from tobacco smoking, again, like tamoxifen. But there is no increased risk of endometrial cancer versus tamoxifen. So you can relax. Used primarily to treat postmenopausal osteoporosis. It's interesting how, because of just one shift, one receptor shift, the drug is used to treat something else, and it has also decreased the risk of endometrial cancer. So, it is used to treat postmenopausal osteoporosis because it has no pro-estrogenic effect on the endometrium, unlike tamoxifen, which has pro-estrogenic effects, and it has similar effects to tamoxifen, which are hot flashes and increase of thromboembolic events. The hot flashes were there in clomiphene as well, so hot flashes in all three of them. Ovarian enlargement, visual disturbances, and multiple pregnancies in clomiphene because it is associated with treating anovulatory infertility. Tamoxifen is used for treating breast cancer, and thus it has hot flashes, increased thromboembolic events, and increased risk of endometrial hyperplasia. Raloxifene has hot flashes as well, but it is used to treat postmenopausal osteoporosis, so it has no risk for endometrial cancer um, or breast cancer for that case. Next, we have aromatase inhibitors. These are anastrozole, letrozole, and exemestane. So zolzol and mestane. Aromatase inhibitors, we have discussed these here. They prevent the conversion of androstenedione into estrone. Androstenedione into estrone. Aromatase inhibitors. So they inhibit peripheral conversion of androgens to estrogen in the periphery, because the normal conversion is in the cholesterol adipose tissue. In the cholesterol, gets converted normally into androgens and then to estrogen, but the peripheral conversion is in the ovaries, where androgens are getting converted to estrogen, and anastrozole, letrozole, and exemestane are going to act there. The clinical use is estrogen positive breast cancer in postmenopausal females. Letrozole can be used to treat infertility from anovulation, for example, PCOS. So because it is preventing the formation of estrogen, it is going to decrease the estrogen positive breast cancer. And because they are going to decrease the formation of estrogen, they are going to treat infertility from anovulation, which is because of unopposed estrogen and very little progestins. So as the estrogen is going to be less in amount, there is going to be ovulation, and the infertility would be treated. So anastrozole, letrozole, exemestane used for treating anovulatory infertility and ER-positive breast cancer. The next are progestins, which include levonorgestrel, medroxyprogesterone, etonogestrel, norethindrone, and migestrol. I have studied levonorgestrel, medroxyprogesterone, and norethindrone somewhere. I've also read about etonogestrel and megestrol, but not that much. Megestrol. So there's levo, levonorgestrel, etonogestrel. Okay, they're such messed up names. Levonorgestrel, etonogestrel, megestrol. Okay, so there's like an R difference between the levonorgestrel and etonogestrel. Like it is not etonor, it is etono. And there's an E and O difference between the etonogestrel and megestrol. And this one is medroxyprogesterone is simple, and norethindrone is somewhat difficult to remember because it has no gestrel or gestrone in it. So the mechanism is that they bind progesterone receptors, they decrease the growth and increase the vascularization of endometrium, and they thicken the cervical mucus. So they increase the vascularization of endometrium and basically do what progesterone does, and they decrease the growth and they thicken the cervical mucus to prevent entry of any of the sperms. Clinical uses obviously in contraception. Forms include pill, IUD, implant, or depot injection. They can be given in any form. Endometrial cancer can be treated with them. Abnormal uterine bleeding can be treated with them. Progesterone challenge is the presence of bleeding upon withdrawal of progestins. It excludes anatomic defects, example Asherman syndrome, and chronic anovulation without estrogen. Okay, so I'll have to search what the progestin challenge is. Okay, it is a diagnostic test used to determine the cause of amenorrhea by assessing estrogen levels and endometrial responsiveness. It is used for women who have secondary amenorrhea, the absence of menstruation for 6 months in women with previously regular cycles, or 12 months in those with irregular periods. After pregnancy has been excluded as a cause. The test involves administering a progestin medication, most commonly oral medroxyprogesterone acetate, which comes with the name of Provera, 10 mg daily for 5 to 10 days. The alternatives include norethindrone acetate or micronized progesterone, and some protocols may use single IM injection of progesterone. The patient is then observed for withdrawal bleeding, which typically occurs 2 to 7 days after the last dose. If the bleeding occurs, it indicates that the patient has adequate estrogen levels and a functional endometrium but is not ovulating. Okay, so in the patient, the bleeding is not occurring, and we give progestin and then observe if there is withdrawal bleeding, then withdraw it and then observe if there is going to be bleeding. If there is bleeding, it means that the patient has adequate estrogen, but there was a lack of progesterone, and because of the lack of progesterone, which is now provided, the patient is now bleeding. But if there was no bleeding, it suggests that there could be low estrogen levels or problem with uterine outflow tract. Example, Asherman syndrome or cervical stenosis. Okay, I need to search Asherman syndrome again. So if there is no bleeding, that means that the patient has anatomy defects. Okay, it's quite tissue forms of lead to menstrual irregularities. I remember it now. There's going to be a lot of tissue, yes, in the uterus, and this is going to cause bleeding to not be possible. And chronic anovulation without estrogen. So in this challenge, if there is bleeding upon withdrawal, that means the progesterone levels, the estrogen levels are normal, and if there is no bleeding, then it means that there is some anatomy defect like Asherman syndrome or chronic ovulation without estrogen. Next, we have antiprogestins, in which we have mifepristone and ulpristol. Ulipristal. The mechanism is competitive inhibitors of progestin at progesterone receptors. Simple. The clinical use is termination of pregnancy, mifepristone with misoprostol, and emergency contraception, which is ulipristal. So they're basically used for termination of pregnancy and contraception. Progestins are known for doing such. And the inhibitors of progestin and progesterone receptors, so they do not allow the progestins to bind, and thus they do not cause the pregnancy to occur because they are going to not bring the endometrial changes that are required for the pregnancy and the corpus luteum involute and such as such. Next is contraception, which means birth control. There is going to be hormonal, IUD, and surgical. The hormonal method is estrogen combined with progestins or progestin only. Progestin is like I can do it alone, but you can tag along as well. The mechanism is that they prevent ovulation by decreasing gonadotropin releasing hormone. When there's going to be increased progesterone and estrogen, the gonadotropin releasing hormone is going to have um, a negative feedback effect, and then the LH and FSH decreases. So there's going to be no estrogen surge and no LH surge. When there's no LH surge, there's going to be no ovulation. And the progestins also thicken the cervical mucus and decrease sperm entry, and they also thin the endometrium. make it less suitable for implantation. The forms include pills. There's going to be hormonal OCP pills, transdermal patches, and vaginal rings, whatever you want to have. Um, okay. So what I was looking at was that these cause termination of pregnancies by competitive inhibition of the progestins, and the progestins, when given in high amount, can also cause the negative feedback of gonadotropin releasing hormone, and thus there's going to be a decrease in the effect of the progestins. Sorry, of the estrogen and the LH surge. Then we have IOD, which is copper IOD, hormone-free, and progesterone IOD that is not hormone-free as given by its name. The copper IOD causes local inflammation that is toxic to the sperm and ova, preventing fertilization and implantation. So it basically goes and causes inflammation that is toxic and kills the sperm and ova, and this prevents fertilization and implantation. Progesterone IOD acts same as progestin, and progestin bound to the progesterone receptor and decrease the growth and increase the vascularization and thicken the cervical mucus. IUDs increase the risk for abnormal uterine bleeding, insertion contraindicated in patients with active sexually transmitted infection and heavy menstrual bleeding. Then we have surgical. In males, there's vasectomy, and females, there's tubal ligation. So tubal ligation is the ligation of the fallopian tubes, but what is a vasectomy? It is a surgical procedure that serves as a permanent form of birth control for men. Surgeon cuts and seals the vas efferents, the tube that carries the sperm, preventing sperm from mixing with semen during ejaculation. Okay, so it is the removal of the vas deferens. No sperm in the ejaculate, and sperm cannot reach the ova, and it is irreversible. So IUD is reversible, but surgical is not reversible. Then are the tocolytics. These are medications that relax the uterus. They include terbutaline, which is a beta-2 agonist action. It includes indomethacin, which is an NSAID. Then there's nifedipine, which is a calcium channel blocker. They're used to decrease the contraction frequency in preterm labor and allow time for administration of glucocorticoids to promote fetal lung maturity or transfer to appropriate medical center with obstetrical care. Keep baby in the tent. So they basically relax the uterus, terbutaline, indomethacin, and nifedipine, and thus they increase the contraction frequency in the uterus. Then we have danazole, another enzyme that acted on two places. Here, it acted on CYP450 system in the ovaries, and it also interacted with the anterior pituitary right here. So it is a synthetic androgen that acts as a partial agonist at androgen receptors, and its clinical use is in endometriosis and hereditary angioedema. It is an androgen, and this is used in endometriosis to decrease the amount of estrogen, obviously, and hereditary angioedema as well, which is a disease that is caused by a C1 inhibitor, a protein in the classical pathway. The adverse effects are that it can cause weight gain, edema, acne, hirsutism, masculinization because of its androgenic-like effect, decreased HDL levels, hepatotoxicity, and idiopathic intracranial hypertension. Next, we have testosterone and methyl testosterone, as given by the name. They are agonists. They treat hypogonadism, just like estrogen analogs, and they promote development of secondary sex characteristics. They cause virilization in females, testicular atrophy in males, and premature closure of epiphyseal plates, increased risk of acne, increased erythrocytosis, increased LDL, and increased HDL. They increase both LDL and HDL. Then we have anti-androgens. The first is abiraterone. It is in 17-alpha hydroxylase or 17-20 lyase inhibitor. These enzymes are involved in the formation of steroids in the adipose tissue. So it decreases the steroid synthesis, and it is used in prostate cancer. The adverse effects are hypertension, hypokalemia, which is because of increased mineralocorticoids. There's going to be a decrease in androgen formation, but there's going to be increase in mineralocorticoids that is going to cause hypertension and hypokalemia. An important thing to note in anti-androgens is that they're used to treat prostate cancer, and there are some exceptions, of course, which we are going to do. So, abiraterone, inhibitor of the steroid synthesis in the adipose tissue and causes prostate cancer. Then we have finasteride that we discussed and said that it was very important. It was a 5-alpha reductase inhibitor that inhibited the conversion of testosterone to dihydrotestosterone, and it is used in benign prostatic hyperplasia and androgenetic alopecia. So it causes the decreases the conversion of testosterone to DHT. So it increases testosterone but decreases DHT. And since BPH is associated with DHT, it is used to treat BPH, and also because DHT is an androgen, so it decreases the cause of androgenetic alopecia or male pattern baldness. And its adverse effects is that it can cause gynecomastia and sexual dysfunction because there's going to be decreased DHT. And DHT is important in the synthesis of in the degradation of Mullerian duct and several other female sexual characteristics. It is important in the destruction of them, and so the adverse effects include gynecomastia and sexual dysfunction because there's going to be a very decreased amount of DHT in the body. Then we have flutamide and bicalutamide. I suppose that's what it's called. It is a non-steroidal competitive inhibitor at androgen receptor. It is not steroidal. It is a competitive inhibitor of androgen receptors, and they compete with androgens and decrease the steroid binding. Thus, they are used in prostate cancer, and they can also cause gynecomastia and sexual dysfunction. Then we have ketoconazole that acted at two places again. It acted on here in the formation of inosine and in the formation of testosterone. It inhibited both this ketoconazole, and thus it was a 17-alpha hydroxylase and 1720 lyase inhibitor like abiraterone, but it is used in prostate cancer, and yes, it can cause gynecomastia. Spironolactone was an androgen receptor and 17-alpha hydroxylase or 1720 lyase inhibitor. So it has a dual function. It not only inhibits the androgen receptors like flutamide and glutamide, but also the enzymes like ketoconazole and abiraterone. And it is used for the treatment of PCOS. And in because in PCOS there's going to be increase in androgen, so it is going to inhibit them, and its reverse effects are that it can cause amenorrhea. Okay. Then we have our last two that are temsulocin and minoxidil. Temsulocin is an alpha-1 antagonist selective for alpha-1A and D receptors, which are present in the prostate, versus the vascular alpha-1B receptors. It does not antagonize the vascular receptors, but only the receptors in the prostate. And so it decreases the smooth muscle tone in the prostate and increases the urine flow, and it is used for treatment of BPH. Minoxidil is a direct arteriolar vasodilator, and it is used for the treatment of androgenetic alopecia and severe refractory hypertension. So a fun thing about temsulocin and minoxidil was that temsulocin used in BPH, minoxidil used in androgenetic alopecia, and finasteride used in both. Another fun thing that I like to think about is that flutamide and bicalutamide for the treatment of the mechanism of action for the inhibitor at androgen receptor. Ketoconazole and abiraterone are inhibitors of 17-alpha hydroxylase and 1720 lyase. Spironolactone does both and is an androgen receptor inhibitor as well as 17-alpha hydroxylase and 1720 lyase inhibitor. And it causes amenorrhea, which I'll have to search why it does because I don't understand. What does spironolactone cause amenorrhea? Hmm. Hmm. So they are saying that it has a slight anti-androgenic activity because of which there are going to be menstrual irregularities, including stopping periods. That was about it. We have finished our respiratory module by finishing this pharmacology. See you in the next module. Bye.